Episode 496. Plan sponsors spend about $1.20 to buy $1 of healthcare, and clinical organizations receive 80 cents for every $1.20 spent. What? Today, I speak with Mark Newman.
American healthcare entrepreneurs and executives you want to know. Talking. Relentlessly seeking value.
I'm going to do a little series here called The Inches Are All Around Us. And in this series, at least to start, all of the inches I'm going to mention are full-on administrative waste. Waste that is particularly egregious because it has nothing to do with patient care. That's why when Shane Cerrone said the inches are all around us in episode 492 about hospitals and hospital prices, I really perked up. Because by fixing this friction, this administrative waste, we can actually improve patient care and reduce costs simultaneously. Along these same lines, I have also heard Zach Cooper talk about the 1% Steps to Healthcare Reform project, where he's like, look, find 10 or 30 or whatever, 1% problems, and you'll probably transform healthcare faster than if you're trying to find a 10 or 30% solution. So same idea. And finding these inches, these 1%, even in and of themselves, it's big dollars when it comes to how much the U.S. spends on healthcare, which is, by the way, projected to reach $5.6 trillion in 2025, according to NHE projections from federal actuaries. Links in the show notes. So I decided to go on a bit of a quest for these inches, get a beat on where they may be nestled for anyone looking on behalf of their plan or their country or their state, maybe. To this end, also recall or be aware of the episode with David Schenker, link in the show notes. Everything I say, by the way, that you're thinking you'd like a link for, you will likely find in the show notes because I gotcha. But David Schenker in that episode gets into how much every industry pays something like 2% to administer a transaction. But in healthcare, the provider pays something like 14%, and the payer pays another 14% to submit and get paid for a claim, which is healthcare for a transaction. Don't get me wrong. It's the plan sponsors, such as self-insured employers, members, and USA taxpayers, who are ultimately paying for those 14%. So that 28% of full-on administrative costs, most of which we could agree could go away and probably be better for patients, not worse. This, too, is coming out of the pockets of the ultimate purchasers of healthcare. Those costs are getting passed along. I say all this to say, to kick off this The Inches Are All Around Us exploration, I wanted to dig in a little more specifically into what goes on during these aforementioned transactions, i.e. what this life of a claim kind of looks like on the ground. I wanted to start here because, we haven't done this before. And this exploration is going to continue into next week because we're going to dip heavy into clearinghouses with Zach Cantor and what they do all day. And then after that, I'm talking payment integrity programs. I'm talking prepayment review programs with Mark Newman. Because you know what? Employers don't want to be bringing a knife to a gunfight. And I realized in the course of these conversations that any self-insured plan sponsor that is not doing for real payment integrity programs, for real prepayment review, post-payment review, I'm getting ahead of myself. But when you listen to the show next week with Zach Cantor, you will so totally see what I mean. Today, as I mentioned earlier, I am speaking with Mark Newman, who is the CEO and founder of Nomi Health. Nomi aims to simplify the act of buying and paying for healthcare for self-insured employers. Look them up if that sounds intriguing. Link in the show notes to their website. I also do need to thank Nomi Health for so generously offering to donate to RHV to cover the expenses of producing this episode. So thank you so much to Nomi Health. Okay, lastly here. Just to set the basic framework for this conversation that follows, Mark gets into two main revelations, reasons that kind of sit behind a large part of the waste and friction in healthcare transactions, again, otherwise known as a claim getting paid. And these two reasons are data isn't data. In other words, as a claim moves through the system to different stakeholders, the data starts to change and morph and come and go. Different people have different use cases for that data. So it starts to get added and subtracted, but nobody really has the universal level to tote up the difference in any organized fashion. So we talk about that first. Then Mark Newman doubles down with another reason for the friction and waste. Here's the second revelation. A dollar isn't a dollar. And same kind of rules apply here. A plan sponsor might spend $1. And yeah, is that dollar spent or is that dollar accrued to spend, which is kind of wonky, but also relevant. And if you didn't understand that, we'll get to it. And then just because a dollar gets spent doesn't mean the provider gets that dollar. And by the way, I don't just mean, oh, they're spread pricing. How shocking. I mean that a plan sponsor could roll up to a hospital and say, we spent $10 million last year. And the hospital could say, no, you didn't. You only spent 5. And spoiler alert, in this case, it's not about spread pricing, although it might be. It's also about how much was the member responsibility that the members didn't pay. So a dollar is not a dollar for a whole bunch of different reasons. My name is Stacey Richter, and this podcast is sponsored by Aventria Health Group. And today, it's also sponsored by Nomi Health. Mark Newman, welcome to Relentless Health Value.
Thank you for having me.
So we can talk about the life of a claim between when it gets submitted and when it gets paid, otherwise known as what a healthcare transaction looks like. Short version, it's incredibly fractured. It's an incredibly fractured journey, to put it charitably. And there are many reasons how and why this came to be, and there are many perverse and otherwise incentives for why it continues to be. But that is not the point of this particular conversation. What we're talking about today is why knowing the life of a claim is suboptimal is actually actionable information. And there's 2 actionable revelations, maybe I'll call them, that we want to talk about today. So let's start there. If we're talking about the life of a claim and what can go horribly wrong when the data is so fractured, what is actionable to know about that?
Let's put the different hats on when you look at that data. Data isn't data for different people. So from a data standpoint, a provider has their data and how they look at their business. On this date, I saw these people. I collected, there's this term RVUs. That's a kind of like quota, for doctors' production units on a daily basis or a weekly basis or monthly basis, how many RVUs they need to do. Did I get my RVUs based on date of service? Okay, that's one bucket. Then there's a business operations data stream of that exact same stream of work, right? From like a doctor standpoint, then becomes a business data stream, business operations data, right?
And when you say business operations data, you mean like somebody in accounting who's like, well, these are what our receivables
somebody in accounting
are.
In the provider's office or the health system's office, they have no idea what they're going to collect, how much they're going to collect, when they're going to collect, and they just forecast it, right? It's an assumption. It's not specific. Then it goes over to the payer, the TPA, you name it. They have their own accounting of that claim because they get a gross charge versus a actual billed charge versus like a contracted rate. Was it based on date of service? Who's paying it? Are we responsible for it? Or is the member responsible for it? Okay.
Just cutting in here to summarize, there's a lot of data flying around, but the data set can certainly change in the translation as everybody tries to get what they need out of it.
When you deal with TPAs, there's the operations team and the payments team and the treasury team, and they fundamentally do not operate on the same data files.
But wait, there's more. Okay, so there's a wrinkle that might even make it hard for a payer or a TPA to internally reconcile any given situation, is what it's sounding like to me.
Then, if you're the employer who runs the plan, you get a whole different set. And the reason why you get a whole different set is because in most cases, you see what your responsibility, what your plan spent or is accountable for, then what your responsibility is, your portion or plus all the fees for navigating this whole thing. And so when you look at that data stream, everyone looks at this one event of healthcare, and it might be on a specific episode because maybe it was a big episode, and every single person looks at this as something totally different. And that makes that the data isn't the data.
Everybody, in a way, is speaking a different language. Okay, so if we're thinking about what the implications are of all this fragmentation, and I say this a lot, effective collaboration is going to be the next breakthrough innovation. If you can't even speak the same language, it's really, really hard to collaborate. This is one of those things that you don't realize how powerful it is until you wind up sitting in a meeting and you've got numbers that don't match somebody else's numbers.
Or you're talking to a payer, you're a provider, you're talking to a payer, and they go, oh, that's our ASO business versus our Medicare Advantage business versus our ACA business versus our small group.
There's no, sometimes I call them anchor units, right? Like there's no number that everyone...
Sources of truth.
Yeah, look at your spreadsheet and everyone find where it says this day and $35 and like that's how... There's none of that. So it just makes it very, very difficult to work together to even do analytics. Nobody's keeping track of the same thing.
Or, when it is solved or when you do have that answer, finally, 30% of the cost of healthcare is associated with figuring that out.
And you can start to see why. So revelation one here is that the data is fractured among the multiple entities along the exact same claim journey. They are focused on different parts of the data set. And maybe as a result, there's not one single spreadsheet view that everyone around the table is going to be referencing. Try to negotiate a deal when no one can not only agree on the baseline, but even clearly see what that baseline is from not only just from a number standpoint, but just from a parameter standpoint. Like, what are the fields in the spreadsheet to start with? Everybody has different fields. This might happen organically because different parties have their eye on different balls for probably decent reasons. But there's also, if you think about it, a perverse incentive that they don't line up, right? Like if you're in the business of spread pricing and or arbitrage and you're interested in folks not quite understanding how much you might be hoovering out of the middle of any transaction, then not having the spreadsheets line up between the sellers and the ultimate buyers is actually a plus for you. Okay, so at the top of the show, Mark, you said that the data isn't the data, and I think we get this. But now let me pivot, because you also said to me earlier that a dollar isn't a dollar. Let's talk about what you mean by that.
Okay, so if a provider shows up to talk to a plan sponsor says, we have so many lives that come to you that incurs $10 million a year of claims, and we want a better rate on this part of it. And the provider shows up and says, we have some portion of those lives that come to us, and our net that we get from this is perhaps $5 million. Plan sponsor goes, what are you talking about?
Wait. So plan sponsor thinks they're spending $10 million, but the provider organization only has $5 million on their books. Half that. A dollar is not a dollar, in other words?
Where that kind of Greek and Japanese breakdown happens is the fact that the plan sponsor shows up and says, we have X amount of, charges with you. And we ignore there's a plan responsibility and there's a member responsibility. And in fact, they don't want to get their hands dirty to say our members don't pay, our members can't afford it, our members have too high of deductibles, whatever it might be. They just say, we do this much of service. The provider shows up and says, I'm first bill for most people on this plan. I don't ever get paid because my cost of collection is so high, et cetera, et cetera. So my net that I get is this. And so that's why you have this Greek and Japanese. One person's talking about one number, another person's talking about an entire another number.
Which I could see, if you're trying to do direct contracting, could be a rather interesting conversation, because the employer's coming in saying, this is how much business I have with you. And the provider might be, meh, not so much, really.
Well, even worse, because the employer might be whatever the payer said, because very rarely does the employer have the level of scale. They're just renting the things from the payer, which is like, I don't know, there's Greek, Japanese, and German. There's 3 languages going.
We're just talking about the self-insured employer, or the union. Would it matter if the finance department from the self-insured employer was in that room meeting with the provider organization or HR?
Yeah, if finance and HR they will have fundamentally different answers when they go in. Wait,
what?
That.
So you just said even within the self-insured employer, there might be different languages going on.
Oh, absolutely. So HR will generally have visibility into what's going on and what's happening. And they might say, this is how many expenses we've incurred this year. Here's not only our medical claims expense, here's our pharmacy expenses, but there's a lot of other things that go into this plan cost. Stop loss reimbursement, transactional fees, PEPMs for digital health tools, consultants, brokers, TPAs, all the stuff. So HR kind of in benefits teams, they'll generally have a set number from the beginning of the year. We think we're going to spend $10 million this year or $100 million, whatever that number is. And they're kind of like tracking it like a burn down. Like that's my budget and here's my kind of burn down against it. Finance might get a single invoice from a TPA that they're supposed to pay. Or they might be getting funds pulled from an account supposedly accrued to pay bills and claims that are smoothed out. And so finance might show up and have no idea they're spending $3 million at this provider and $4 million over here or whatever. In fact, most finance organizations are like, all right, we think it's $10 million this year. Okay. We're just fed up. We're just going to accrue it at $833,000 a month, flatten it out. Hopefully we don't overrun it in Q4 and just plan for it to go up 8 or 10% next year. Or they go deep into the matrix and they find out that they have to do accrual accounting and benefits does cash accounting. None of them have any idea what it means for the member if they're actually able to pay the bills that they have.
Yeah. So what I'm understanding, even within the plan sponsor, the self-insured employer, whoever's the ultimate purchaser here, what's even going on within their own organization. And we're talking now about, I'm going to say, the organizations that do not have finance intimately involved with what's going on with benefits, obviously. And I know we have a lot of self-insured employers that listen to this show who may, so not talking about you or not talking about what you know is ultimately the right thing to do, at least. What we've got is the benefits team is calculating what they actually spent, going out the door based on what happened in the claims wire. But then you've got the finance team who can see what got pulled from the account, but how they're budgeting, as you said, the aggregate, the universal number, and then we just divided it by 12 and said that's what we were going to accrue on a monthly basis. So like if you, again, try to have a meeting, even within that one employer,
It's like the finance team got the American Express bill and just paid it. And they're like, we have no idea what was in that American Express bill. It's like, we got the total amount. We have no idea what's underneath that. And sometimes people say that's proprietary, that's HIPAA, like that's kind of the nonsense.
Okay, so we first talked about how data isn't data. That was Revelation 1 about how data starts to transform and or go missing as it travels along the claim journey. Now we're talking about the second revelation, which is a dollar isn't a dollar. And when I say revelation, I mean actionable information about this fragmented claims journey. So we covered how a dollar might not be a dollar. That could be true because of different accounting methods, like using accrual accounting for some things and cash accounting for others. And yes, this is wonky as hell, but if a provider organization uses both methods simultaneously, or if a plan sponsor in different departments uses both accounting methods simultaneously, you won't have numbers that match up. I mean, this is why the IRS makes you choose when you set up a business which accounting method you're going to use, accrual or cash, for taxes. And you have to pick one and only one. Like more is not better. It's calculating the same thing two different ways. And then a dollar is not a dollar, at least in that accounting period. But then also a dollar isn't a dollar because you have inside of payers and maybe plan sponsors rolling all spend up into one big number, but providers are splitting it between what they got from the TPA payer versus what they were supposed to collect from the member, but probably didn't. And look, you might not have followed that whole deconstructed pathway here, and it almost doesn't matter. The point is, this whole thing is a thing. And when we talk about the transaction costs of healthcare being high, all of this, as Mark said earlier, becomes a whole cottage industry to straighten out. And that costs all of us 28-30% of our healthcare spend a year. That's a really actionable thing to know. The inches are all around us. But this one, I don't know, might even be like a foot or a yard. So Mark, if you were going to summarize this whole a dollar isn't a dollar point, how would you do that?
What I mean by a dollar not being a dollar, the employer is paying rental fees to access that dollar of negotiated rates, transactional fees, PEPMs, consulting fees, you name it. And as you stack all those up, that turns into roughly $1.20 to $1.30. So they're paying $1.20 to $1.30 for their members to access a dollar of healthcare. And you can actually see this even in like the ACA plans or the fully insured plans across states, and that's called medical loss ratio. So that was under the Affordable Care Act, where there's $1 of premium and the payers are required to spend 85 cents on care. Now they never do, but supposedly they're there to spend 85 cents on care. So if you think about that 85 cents becoming that dollar, that means that you're paying $1 plus, right? You know what I mean? You're paying $1.20 to get $1 of healthcare. But if you talk to any doctor that you know in your life and you say, okay, you're owed $100. How long does it take you to get paid that $100? And how much of it do you collect? They kind of laugh and cry at the same time. And what you see, and this, you can see this in public companies and health systems, you name it, that it takes somewhere between 2 to 9 months to get paid. And they're writing off roughly 75% of patient balances. And between denial rates and unpaid service levels and claims and codes and whatever, they're collecting like 85 to 90 cents on the dollar at best from payers. And when you blend that together around their business, they go, on my best day, I get 70 to 80 cents of what I thought I was contractually owed for the work that I just did. And on top of that, about 12 to 15% of any budget in any health system or office now is on things like revenue cycle management, administrators, billing people. So it's being spent on the cost of figuring out how to get paid. And so when we think about that, we go, okay, in a restaurant, $1 on a bill, is we as a consumer pay $1. They might get 97 cents if it's a credit card swipe, right? And we all move on. But in healthcare, that $1 means that it's $1.20 to $1.30 to the actual buyer of care, the employer, and functionally the member, because that's how their plan cost gets priced. And on the flip side of it, the provider is collecting maybe 70 to 80 cents. And that right there is $1.5 trillion a year of U.S. healthcare costs. It just goes out the door. And there isn't one boogeyman. Like, it's just the cost of the friction. It's the spread, the margins, the figuring it out, the why nots, the call centers, the noise, the mail. And like, that's the spread. And that's the biggest opportunity for self-insured employers and healthcare in general to solve. If we solve that spread problem, we solve healthcare.
And I think it's important to point out that friction, if we cut it out, a lot of times we think, if we cut things, it's going to be a detriment to the member, or it's a detriment to... This is the exact opposite. Cut that friction out, and it is actually better for members.
For sure, because the provider themselves can't run their business on the hope and dream they get $1. They budget their business, they hire, they make their profit margin, whatever, on 80 cents. And if they collect more, it's upside.
Obviously, there's issues for providers there who are waiting. Payers make a lot of money on the float. So again, none of this, you had said something earlier, which is, this is not just an accident. There's some intentionality here. And if I am going to just hypothesize what you might say, and then I'll ask you what you will say. But if I'm going to hypothesize the why relative to the intentionality, number one, listen to the show with Preston Alexander. And Dr. Eric Bricker mentioned this in a show as well, just relative to, the getting paid faster is not a technology problem a lot of times. It's the carriers want to keep the money issue for obvious reasons, because they make 10, 20% of their profit margin on float or investments that they can make while they have the money. There's a lot of power in having money, even temporarily. So we certainly have the intentionality that is there. But then on the flip side, you have the providers who don't have the money. Therefore, they have to spend more money. And again, referencing that Preston Alexander show, talking about bonds and all. And I am certainly not suggesting in any way that many large consolidated health systems in this country, particularly, in fact, the nonprofit ones, have fiscal discipline. Listen to the shows with Dr. Sam Flanders and Shane Cerrone for more on that topic. But it definitely creates a situation for sure in this particular way. They absolutely are not wrong to have these gigantic revenue cycle management. And then I also will mention Andrew Sang. He put the 27 streams of revenue in between. Provider does something and carrier pays the...
I love that.
And
the 27 streams gave up at 13. I'm like, hey, I'm deep enough in Dante's Inferno here. Like, it's time to build something different.
Yeah, but if we're talking about the intentionality, you think about everybody in the middle there who's taking 1% or 2% or whatever percent, and it adds up to 40%. But nobody in the middle has any incentive to cut themselves out because their entire revenue stream is, in fact, the friction. And I am certainly not talking like I am making a very broad stroke statement there. And I'm also separating out long-term from short-term. That is a thing. You can understand that in the long term, something is really a problem. But in the short term, if you stop doing it, patients would be harmed. I mean, like that's half the ethical dilemmas that I myself wrestle with are, I know that ultimately this is creating a bad cycle, but if you stop doing it, then you're going to have patients that are caught in the crossfire. And what do you do there?
People are putting off care. People aren't getting raises and, being able to handle a cost of living increase because premiums go up 8 or 12% every single year. So patients are in the crossfire. And so now it's a function of what do we do about this? Because now, before it was just the members, but now businesses and businesses aren't just highfalutin Fortune 500 companies that complain. Like no one needs to cry for Jamie Dimon or Jeff Bezos and his healthcare costs. They're good. They're fine. But school districts can't hire teachers because their healthcare costs are now $40,000 per family per year and just went up another 8%, 10%. Well, that's $4,000 that they now have to come up with on a per teacher basis. And it turns out if they can pay teachers $64,000 instead of $60,000, or over the course of 3 years, $75,000 instead of $60,000, they'll have a 30% lower vacancy rate. They'll keep more teachers. They'll have less turnover. No, we can't do that because we have to keep handling this benefits cost. And, it's like Charlie Munger said, if you figure out the comp model, I'll tell you exactly the outcome you're going to get, right? HR 101, you get what you pay for. And if you look at what people get paid for at the biggest payers in America, they're all public companies. Revenue per share, earnings per share, profitability, gross margin. And I don't care if they're for profit or not for profit. They all get paid for the same shit, kind of on this part of it. So as a result, they do not get paid for revenue to go down. They do not get paid for margins to decrease. They do not get paid for United had their earnings go down, something small on the grand scheme of things. And their stock price went down 50% over the course of a couple of weeks. So what are they going to do? Their CFO was in Becker's saying, we're going to bring the swagger back to United. And I'm telling you, swagger for United is not good for America. And so it's not even hard to figure out. It's what do people get paid for? What do they get their bonuses on?
How do we fix this, Mark?
When you talk about there's 27 layers, in that journey of the bill, the 27 layers, any one of those layers isn't going to change the trajectory of U.S. healthcare. So that's why we believe that the only way to do it is to kind of bypass the 27 layers. And that doesn't work everywhere, but it can work for self-insured employers because behind every payer is a buyer who hires them. Self-insured employers know how to buy things and pay for them. They know how to negotiate. They know how to deal with cost of goods sold, you name it. But the industry hasn't been equipped or it hasn't been enabled to serve employers that way. You're seeing green shoots, but there isn't the infrastructure for an employer to take advantage of that. And that's where I think there's the next big opportunity in healthcare, whether it's us, whether it's new entrants, whether it's digital health. And we think, in our personal lives, I can book a flight to Miami and it comes up with a rental car and a hotel and show tickets and weather and whatever and a price. But in healthcare, if I book a flight to Miami, I'd get a rental car in New Jersey, a hotel in New York, weather for Seattle, and a price for it 6 months later. That's not something that you can incrementally fix.
Sandra Raup on LinkedIn just wrote a comment, which was short, but I think incredibly powerful. She said, we're over tweaking. It was something like this. You can't tweak anymore. Yeah. We're done.
Yeah. I can get a phone call. Hey, Mark, you didn't do this charge. Is this you? We never questioned the validity of the bill on our American Express. And we're not going to get a new, better system from the people with their hands in the honeypot. They have no incentive to it. And so we have to, and that doesn't mean that all has to disappear. What it has to mean is who are the parties that matter? And if we said, well, providers matter, obviously. Drug manufacturers, they matter, obviously. We need them. We need a method of distribution, right? We need to be able to get drugs to people. We need to get healthcare to people. But then who pays the bill? If we can simplify that, where it says, here's the care that you delivered, and you just got paid for it, it works. We've been experimenting with a no copay, no deductible model, just to say, is part of the ambiguity here and the problem of the cost of this ambiguity a function of too many parties involved, right? What happens, whether it's a $100 primary care visit to a $100,000 surgery, if you just take the member out of it?
And you're talking at Nomi Health right now.
Yes, we just said, listen, we're going to go rip this thing apart. We're going to have it all data driven, all digital straight payments, no copays, no deductibles. And we're going to price in the risk. We're going to see what happens. Let's kind of go do this. And 3 things happened. One, The contracted rate we found with the providers when no ambiguity of collections for the services that I just delivered. So we call that the real cost of healthcare, right? The real price was roughly 20 to 30% lower than a BUCA traditional contracted rate, which for us is pricing in the risk of non-payment. That's the difference. If you have zero risk of non-payment, then it's this price. If you have to price in the risk of non-payment, then it's that plus. Simple. If a restaurant had to do it, they'd do the same thing. The second factor was what happens to utilization patterns. Because the myth is you need copays and deductibles to mitigate utilization. Does that make sense? Like if you don't have copays and deductibles, healthcare is going to go crazy and whatever. Now, this isn't Medicare. These are working age families who have other things to do in their life. There's like a natural limiter to how much healthcare they're going to be able to go and get because it's life. So it turns out total number of claims, like just claim volume, utilization went up like 7-8% in claim volume. But mix, that 7-8% increase in claim volume was a bit more mental health, more physical therapy, more primary care, bit more specialty visits. All the things that people put off because they were underneath their deductible. The other mix, though, is what breaks the self-insured plan isn't primary care. It's NICU babies, cancers, accidents, and there weren't more of those things. There weren't more NICU babies. In fact, we're going to find out if there's less, but there wasn't more of those things. And then the third dynamic was, and this is like Malcolm Gladwell, so I'm not even sure what to call it yet. But think about in our own personal lives, what we've done from a behavioral economic standpoint. When you hit your deductible, there is such a fascinating acceleration of utilization.
I did a whole show on that called Moral Hazard something or other. If anyone wants to listen to a 15-minute rant.
Let's go get that ankle surgery. Let's go do this. Let's go do that, right? Well, what happens if behaviorally you don't have to worry about that now? And we've been watching it. And it didn't take 2-3 years to figure this out. It took one. It literally just smoothed. It just smoothed out. And so in this pilot area, you're now seeing a 38% decrease in healthcare costs.
Wow.
And, we need to see the whole year prove out. But even if that cut in half because people went and got that care and whatever, 20% healthcare cost decrease.
And what's exciting about that even more so is that is coming from the just friction, the cost of
removal of the friction. The providers are over the moon. The employers are winning awards. They're getting rounds of applause at their benefits meeting.
And the interesting thing is Dr. Stanley Schwartz was on the show from Zero Health. He was talking about something similar with direct contracting. We had Dr. Kristen Dickerson who said a similar thing. So this is something which is, hey, cut the cost of friction and everybody wins except potentially the 27 revenue streams that sit in the middle there that, again, may be necessary in a really dysfunctional system. But if you make the system functional, they are subject to the innovator's dilemma, right? Where
for sure.
I am referencing the seminal book by Dr. Clay Christensen, who explains in that book, for example, why Kodak crashed and burned when they could see the writing on the wall probably just as well as anyone else. Why they crashed and burned? It's because when you are the incumbent and you're making a whole lot of profit off of doing something the hard way, you aren't going to cannibalize those high profits by promoting a new and better and more agile and streamlined way. Your company just can't do it. It's too much cognitive dissonance. It's too many folks with too much personal vested interest in not causing their whole department to get laid off. It makes sense.
One of our main investors and has been at Nomi was Clayton Christensen and his son, Matt Christensen.
No kidding.
Oh, yeah. No, they were in Nomi before he passed. Matt's on our board. And this is core to every single thing that we believe in. And you have to start at the basics and you just keep going further up market. And I think in self-insured healthcare, we can be the blueprint for the right system for America, but we have to prove it. And the other thing that I think is important is the problem with VCs and even private equity firms, that you have this kind of dynamic where some initial traction, you have a brilliant idea, then you get a bit of money, and then you have revenue hurdles that you have to hit and growth that you have to go deliver back on. And what do? They go, oh, it's really hard to go do that thing. It's really easy. Let's just go get a deal with Cigna. Let's just go get a deal with Centene, let's just go get a deal with, right? And it's this dynamic where that starts happening. And it's why you start seeing all these digital health companies in their IPOs. They go, 70% of our revenue is from 3 payers. And you're like, got it. So are you going to change things? Or are you just going to get 70% of your revenue?
That's true across the board. Like, go talk to a pharma company. You're going to hear exactly the same thing, right? Like, oh, we can't piss off the PBMs because then there goes 80+% of our revenue that comes from 3 players. So talk to me about Nomi Health.
So at Nomi Health, we work with the employers and their TPAs, and we do 3 things for them. 1, we are their analytics platform to break open the black box. 2, we're their payment system to take back control of their money, right? Rather than outsource that and kind of separate that out. And 3, we then take the fact that we know where you spend your money and how you and move your money to then buy direct access from employers. We have about 19 million lives on our analytics platform already because people want to break open that black box. We recently received our bank trust charter in the state of Nebraska and have been building out the newest and kind of modern digital payment system to providers. And we're about 40% of providers in America right now. And then third, kind of off of that, is building out these direct contractor relationships.
Mark Newman, if someone is interested in learning more about Nomi Health, other than what you have talked about here, where would you direct them?
Come visit us at nomihealth.com. That's NOMI health.com. Or even reach out to me at mark@nomihealth.com. We are building the Rebel Alliance and want more members.
Mark Newman, thank you so much for being on Relentless Health Value today.
Thanks for having me.
Hi, I'm Chris Deacon with Versan Consulting. If you're listening to Relentless Health Value, we already have something important in common. You care about fixing what's broken in healthcare. This isn't just a podcast I tune into. It's one that I revisit, reflect on, and highly recommend. Stacey's conversations don't stop at the mic. They spark ideas, challenge assumptions, and fuel the work so many of us are doing to fix healthcare. If you're here for real change, you're in the right place. Subscribe to the podcast, sign up for the newsletter, and let's keep the momentum going. Thanks for listening.